welcome. It is so lovely to have you here, Elva.
Hi, Diana. Thanks so much for having me. It's so nice to see you again from afar.
Nice to see you. So we met at Patient Day, at the Patient Day conference for EndoFound, and we hit it right off because we were able to meet. We were able to just go connect with someone you've never met, and immediately within 30 seconds, we were telling each other our endometriosis stories and comparing notes. And from my side of things, it was like just click, click, click. It doesn't matter kind of what country you live in. If you have endometriosis, the common thread is the common thread. And tell us a bit about your journey, where you're located, because I find the fact that here in the United States, our healthcare system just varies so much from what goes on in the UK.
Yeah. So we met at Patient Day, and I was over there from Ireland. So I'm near Dublin, but I lived in the UK for about 10 years. So I kind of seen both sides from a healthcare perspective there. Grew up in Ireland and I came back here about 5-6 years ago. And I loved coming to Patient Day. It was so great to just connect with people, and that the common theme doesn't really change, and the countries can change, and the healthcare system can change, but that the common theme is just that kind of lack of understanding, but also this really lovely community of people who just want to share stories and try and kind of lean on each other. So I'm in Ireland. I've just turned 40 last week. But I was diagnosed in the end of 2019. So I would have been, say, 36, nearly 37. But that was when I had this final, I suppose, name for something that had plagued me for years. I'll be honest, I really didn't actually think I had what was going to come out as an actual labeled, named problem, until a friend of mine, only in the months coming up to that laparoscopic kind of investigation, who has very, not mild, I'm not to take it from her, but she hasn't really had issues with it. But I was saying some things and she was like, oh, you have endometriosis. And I was kind of going, I've heard of this thing, but no. And I guess the reason for that was twofold. One, I do come from a family of a lot of heavy bleeders and a lot of sufferers. So my mom and her sisters, a lot of early and younger hysterectomies. My grandmother on my mother's side actually died of uterine cancer, and we never really know, because it was during the 1970s, we'll never really go back, I suppose, and know if there was anything there history wise. My mom and her sister don't, however. They were never given a diagnosis of it, but they did have very large uterine fibroids and very heavy bleeding. So I've grown up in a house where it was just the way things go. It was painful from the start. Periods you weren't meant to suffer. I was never told, you suffer as a woman, but I was kind of told I was like that, as in my mom and my aunt, and we kind of suffer like that. My sister, interestingly, never had much of an issue with that. But interestingly, she's 44 now, and I'm trying to nudge her into my specialist office, because she's started to show kind of things that are a bit more consistent, and it might be different. She has had 2 children. But yeah, back to me. I just grew up. I got my period when I was 11, so I was young, and it was kind of a mess from the start. Just all those real traditional, things we hear about, really heavy bleeding, really painful periods. And in my teens and 20s, I think the worst of that typical menstrual pain, that real burning and cramping and sciatic pain and very heavy periods. And a lot of it contained to that time. It was into my later 20s and 30s that it started to just creep out into your whole weeks. You're just kind of every day. And I'll be honest, I didn't put 2 and 2 together to think that it was linked. I just, again, probably I was going to GPs, or you call them family doctors over there, or primary care doctors in different countries. And it's hard. I don't want to insult anyone, but I guess the truth is I was getting fobbed off, or I was getting turned away. I was kind of being told it was normal, or I was being told, when I had mid-month bleeding and my smears were clear, I was told I'm exercising too much, or I needed to improve my diet and eat more healthy, or I was run down, I was partying too much. So I kind of went through my 20s and into my 30s, just really struggling a lot, but the symptoms did change. And really interesting thing that came up, I'm not sure if you remember it from Patient Day, was how they've now kind of got enough of a body of information to know that certain things start to not attack the body almost at certain ages, and definitely into the 30s is where the bowel starts to get impacted a lot. And that was a big thing for me. But again, why would you associate your bowel with your period? It just didn't make sense to me. And I did go to some doctors and talked about rectal pain and really bad constipation and a lot of nausea, and was just kind of told, well, loads of other things. So I think my endometriosis is there for a lot longer than diagnosis at 36. And by the time I was diagnosed, it was, I also had adenomyosis. But I had endometriomas. I had a lot of adhesive tissue and lesions. And it was on my sigmoid colon, which is kind of that later part of your colon. So in the space of that first year from diagnosis to pretty much 9-10 months later, I had a kind of diagnostic procedure, and then I had a big kind of excisional kind of procedure where I had a bowel resection, I had a hysterectomy, and I had one of my ovaries removed. So that was kind of a long wait, and then a lot of kind of treatment. And then what I honestly thought was like the book closed. For some things, it was obviously when you have adenomyosis, that's gone, right? That's endometriosis doesn't have a cure, but adenomyosis does. If the uterus comes out, that's gone. But I've had different challenges. So I hoped I was going to be one of those people who'd be able to kind of say I had endometriosis, but it just hasn't been that way. And that's where, for me, the community really comes in for the longer journey and the continued journey. So that's my not so quick nutshell of.
No, I think what's upsetting, and we know this, is that if we can get diagnosed earlier, right? If your onset of your first menstrual cycle was 11 years old. So to be 11 years old and then wait until you're in your mid 30s for a diagnosis, that gives the disease so much time, because we know that endo doesn't just burn out. It's a chronic, complete body disease. So it just, like you said, it just gets more and more into different organs. Yeah. And I always try to explain endo in the layman's terms of, like, imagine getting a piece of gum on your sneaker and then walking around with this piece of gum all day long, and you are going to spread this gum all over. And that's endo. So sure, it could start in the reproductive organs, but then it just spreads all over various organs in your body like a chewing gum, and that kind of viscous nature. So early intervention is key, but we know that it takes at least 10 years on average for diagnosis. And a lot of times, like you said, you get told these crazy things. Like, I love and I mean this in a snarky, I love way of, you're working out too much, you need to be healthier, you need to eat better. It's like that doesn't even align. Yeah. But so many times there's so much dismissal. So to have all those years go by and then to have your organs get destroyed by this disease, I mean, the earlier we can get into it. So I know we talk about that early intervention, but for those of us who then are diagnosed after having it for a decade, we're advanced. And now it's like, okay, what do you do?
And consequences, because I guess that's like, and just to come back to the early intervention, I think, and it's a big thing I'm kind of just chipping away at, even in my own friend circle, is like kind of, especially people with kids, daughters and sons. I think everyone should know, obviously we all need to know the differences between male and female bodies, but to me is like, what is normal? And I've had discussions with some of my male friends who have daughters to say, like, do you know, even for you, what normal looks like, just to kind of start that education there. Now, not everyone can then run to a doctor if they get cramps, right? So, it's kind of a hard one too, but kind of understanding what's normal. And that needs to go right the way through, like school, everything, so that, it's not just, the people experiencing it. So that someone could go, I don't think that sounds very right. But yeah, so that's like, I think there's the two big things. I think there's the early end where it's like intervening, where, education and knowledge. But the other side that you mentioned there, where it's, I think there's a lot of people who reach a point where I think I'm at now, and I've other, people I've gotten to know where it's quite possible, that right now actively, because I had so much, if I had really great excision done, that surgeon got everything that was actively endo out, or certainly that was visible. What I struggle with a lot at the moment is then that not kind of that willingness to link the consequences if it's not active disease. And I really struggle with that here in our healthcare system a bit, with the multi kind of disciplinary element, because, you know, they're kind of saying that doesn't sound like the disease is back. And you're kind of going, yeah, but I have a bowel that, you know, was part of it was removed, or my digestive system is just, you know, kind of, you know, messed up because of years, like you say, of inflammation and up and down and, you know, surgeries and procedures. But no one's able to really take that into their specialty. Maybe they're nervous to kind of start tackling it if they don't know, but it's hard to find physicians that will kind of, I have found them. I found one or two who are like, I don't know if I can solve this for you, but I acknowledge that this is not you, this is not nothing. And I think it's linked to your endo. I don't know if it is your endo, but it's linked to it. And I think that's a really big thing for like you say, for us who are the kind of more severe, complex cases, is that, yeah, and we all hear about menopause and hopefully, you know, those ovaries turn off and the hormones all calm down and that's it. That may be for an active disease, but what about all the consequences? So I kind of like to kind of put my time to like the young end, where you're kind of trying to get people diagnosed early. But I think there's a lot to be done as well on the I suppose you could call it the aftermath, right?
Yeah, I feel like the early intervention is key, but then there's a huge population of us, myself included, that are, you know, we're the complex cases. I saw a gynecologist recently, just, you know, general gynecologist. I moved back to my home state, and I was looking for just someone to see annually. And he said, I went through your file, and he said, you have really severe endometriosis. He's like, I don't even know if I'm comfortable seeing you, because I don't want to miss anything here.
Yeah.
And he was honest, and he's been practicing for at least close to 3 decades.
Yeah.
He just said, I think I know endo, but not to the extent where you need that kind of help.
Yeah.
So,
And you know, it's hard too. I think there's so much being done. I have a real scientific background and quite a kind of scientific nerdy mind, but I do tend to keep abreast of studies, and that has loads of studies happening, more than have been before. And that's great. But it's so interesting. And it's the world of trials and clinical trials, is that all the people that you take into those are going to be, you know, younger and newer disease. They're not those complex cases. So we're between a rock and a hard place when you're in the aftermath, as I call it, where if anything, that's the end. That's not going to really maybe get so much intervention and research in future. So I think you just got to build that network of physicians and clinicians who are, and it might be that trial and error, it might be that things come along and they might want to try different approaches to things, and everyone has their choice. It's just, there's nothing kind of, I don't think there's anything groundbreaking going to be out there for the more complex later diagnosis. But I mean, that comes back to that point of, then don't let anyone get diagnosed so late, you know, that it has gone so far. And yeah, it's a kind of hard one.
I hate that we're at this point where it's like, take your organs out.
Yeah.
You know, take your organs out.
Yeah.
And I've had a lot of organs taken out. So it's just kind of like, do I want to feel better? And then also, we know, not to jump too ahead, but we know that with new studies, that the fallopian tubes, the end of the fallopian tubes that connect to the ovaries, that's kind of where they're believing now at this point in science and medical research, that's where ovarian cancer starts.
Yeah.
So when you have advanced endometriosis disease, there will be a time in your life where the recommendation, once you've gotten your, you know, fertility concerns addressed, to remove those, because it's because we know ovarian cancer is largely asymptomatic, and by the time it can be symptomatic, the survival rate is so low.
I know. And it is interesting that like that. And I remember when I was reading about that, and that whole idea of like, that it's not actually the root in the ovary. I mean, it is, but I'm down to an ovary, like, and I'm trying not to be flippant, because I'm very Irish. We used humor in our defense, you know. We kind of are like, it's like a whole country of Chandler Bings from Friends, because we just kind of feel awkward, we make a joke about it. So you'll hear me making jokes about that, like rattling around, there's nothing inside there. It clearly was very difficult, and still taking me time to get used to that. But I'm down to one ovary and no tubes, no cervix, no uterus. But interestingly, that ovary just keeps misbehaving. And it's a kind of a love-hate relationship where it blows these cysts all the time, or it's an endometrioma that they don't tend to kind of like decrease and fill, but it's not a truly hemorrhagic cyst. And if anyone's newish to all these terminology watching this, don't worry, we're not doctors. You just get very specific in your own area, don't you? But yeah, like it's not a traditional hemorrhagic cyst. It's thick and it's kind of septated and it keeps getting bigger and smaller. And I know that there's one specialist I've worked with who'll just say, this is just, just let's just take it out. And I like that, I was 40 days
and
ago.
but there you go with,
it's way too young.
Too young, because it's admitting, right, the yucky stuff, the stuff that is making you sick with endo. I'm in the same boat. I have one ovary left and no fallopian tubes. I do have my uterus. But I same thing. It's like, I know it's chronically cystic. It's chronically a problem.
Yeah.
And it was supposed to be taken out, but the other one was worse when they went in.
That's exactly what happened to me. The first time interestingly, I forget about it in the scheme of things, but I had an ovarian cyst when I was 17 that I had surgery on, and it was on this remaining side. And so my whole life, I've always been like, ooh, this is my dodgy one. And then unfortunately, there was no plan, but when I woke up from the bowel resection and hysterectomy, my left ovary had gone, and it was because it was so kind of wrapped up in this mass of the bowel. And and my surgeon was like, I don't take organs for no reason. He was like, I just couldn't retain that. But I ended up with my bad one left. My problematic one.
Well, and then there's the whole thing, like you said about like we're going back to the aftermath. It's like you take that ovary out at 40 years old, and even though it's admitting the yucky endo stuff, it is giving you natural hormones. So it's bone density, early death, early heart attack,
and cardiovascular protection, and all of this stuff
all of it.
Like, not to say I know people who've had, double oophorectomies for a number of reasons, cancer, and look, there's nothing wrong. Like you can live your life. It's about if the option is there, and HRT has come on over the years, and, it's very different to years ago. But if you don't want to, or you don't have to, and also because of the knock-on of other things, like I've got that ovary in there trying its best and it working hard, and it just keeps things as natural as possible, because it's not just my ovary. My bowel has still got really issues with it. I've noticed I have a tricky gallbladder, which is being looked into now, which again, some people would kind of look at and go totally unrelated, but other good physicians are going, this is, gallbladder, digestive system. You had lesions up near and around, like, and you're just kind of going, it's all linked. So if anything can stay there naturally as long as it can, I'm a big believer in that. But it is hard. You will come across loads of people who'd say she's mad, she should just get that ovary out and just move on. But
you have to be, like you said, there are things that like a doctor or surgeon will say, I just couldn't retain this, I couldn't do it. But then when you have a choice, especially when you've had a lot taken from you, it's very hard to keep.
And I think the other thing is, like, so my surgeries were, again, all surgeries a choice, unless you're kind of, God forbid, you're dying on the table.
Can I just interrupt you real fast?
Yeah.
I get upset over the surgery by choice when your bowel was being, if you have bowel obstruction, you can have sepsis. I mean, there are lung collapse issues. There are.
Well, that's true. I guess I use that term. Like, I guess it was that whole thing. I suppose maybe I'm defensive of some people, because I actually, and maybe it's a point not to labor on, but like, I'm not so public about, here I am with you, but I'm happy to speak to people. I'm happy to tell my story, but I've just seen others, and I've had a little bit of that kind of commentary on, you let someone do this, you let someone take those organs. And so I use that choice of, like, it was surgery by choice. But you're right. Like, I didn't know when I was sat down to have like the serious discussion about my bowel. It was like, I was like, well, how long could I leave this? And they were like, well, nothing's going to happen to you tomorrow. But I've had bowel kind of, subacute bowel obstructions. And they're like, this is where that would probably head. And you don't want a full very serious
No,
bowel obstruction
no. So
or lung collapses. I could not believe how many people have repeat lung collapses. My favorite story from patient day was the person who kept getting told, don't worry about them because they're quite common in tall, slim males. And she was kind of standing there going,
yeah.
I'm not a tall, slim male. So,
right. Well,
but no, you're right. They're life and death situations.
Right. And the extra pelvic aspect. I mean, I had been diagnosed with endo and I was just about to turn 33. Also got my period at 11. Same thing. Years and years of just being like, oh, well, that's what it never heard endometriosis, was put on the pill at like 15 because I had an ovarian cyst burst.
Yeah.
It was incredibly horribly in pain. I lost 5 pounds in like 2 days. It was insane. And it was just told, oh, here's the pill. She just has ovarian cyst, no big deal. And that was that. Put a Band-Aid on it, move along. I was diagnosed 32, 33 with endometriosis and infertility. And then it wasn't until I think my second excision surgery that I learned that endometriosis could be extrapelvic.
Yeah.
I had no idea. And then the third surgery I had, I was close to going into renal failure.
Yeah, I
and
remember you telling me. Yeah.
How do you? And I again did not know that endometriosis could affect the kidneys, ureter. So like I just feel like from a megaphone to discuss this because you got to get out of this thinking of like it's just bad cramps. And as much as we say like we in the community, I think we've done a great job. I think there's so many amazing people using their platforms, their voices, films coming out, research coming out. We have such an amazing pioneering group of scientists, doctors, advocates. But it's like for the general population, it's like, please understand that this is a very serious disease. This is not just pain. Like losing organs should not even be on the table here.
No, and also not to, because there's just truth in it, right? It's not for everybody. Because I'm also like that, because I know someone whose daughter was diagnosed recently and they know my story and they were like, is this where we're headed? I was like, not necessarily, but not to let the fact that some of the extra pelvic and some of the more extreme ones, they are rare, but not to let that be the reason then to go, it's super rare, so don't worry about it, because then you'll kind of never do anything about those. I think like we've touched on one thing earlier about the education of like yourself, but the other thing for me is education for like the medical community. And I'm a big believer as well in trying not to attack anyone who first of all chose a vocation, because I think medicine is vocation, if they haven't been educated. Like I have my own GP has admitted herself, she's like, I went back to some of my friends recently and said, she's in her 50s, but she was like, was I asleep? Did I miss that semester? Did we cover it? And they were like, no, it's not, so it's not in there. And you could be years waiting to get into a specialism and have enough time on rotations and stuff the way they do it that they would get into those details. So I think it's kind of hard, like, the medical community needs way more education in it, but you can't just attack them. It's someone doesn't know. Like that was really good to hear about that gynae there going, I'm a bit nervous about you because I don't want, like, at least they're being open about it. I suppose where the community falls down a bit is those people who, and that's in every walk of life, is those people who just like taking a chance. And you do hear of that, and that's not fair. Those doctors that say, I've sorted that out for you, and haven't used the right techniques, or maybe haven't done the right tests or didn't address it. So, but I really feel I try to kind of defend the medical community, and I've come across some people who definitely gaslight me. I'm not happy about it, but I kind of feel like they didn't know.
Right, they didn't know.
But they should put their hands up and say, I don't know, but they didn't know.
That's a hard thing to do for some people, right? Human frailties and flaws.
It is when you got 7 degrees on your wall. I'm thinking, I didn't know this. How did I not know?
Exactly.
But it is crazy.
I also want to discuss, as we kind of wrap things up here, about what you encountered being in Ireland in terms of the healthcare system. How does it work there?
Okay, so Ireland, we have a public system, we have public health system. If anyone's listening and aware of the UK where there's the NHS, or even if you just watch TV programs, you'll have heard of the NHS, a very large public system. It's not the same, but there is a public element that everyone is entitled to, right? And if you're working, you know, some element of your tax conversation goes to our public health. So there is gynecology and obstetrics on a public level. The problem is the availability of specialists in general that are aware of kind of endometriosis, that do the minimally invasive surgery. But in Ireland, everyone who works has to do a kind of a public element, and then they can have private lists. But the public lists are so big here. I mean, you're talking about, I've heard of people waiting a few years for, they might get the consultation to identify that they think they have endometriosis, but they could be a few years waiting for a lap. And so they are really trying to move away. And I know they're trying to move away from the lap being the only thing you can have to diagnose. So a lot of people will end up on a public system. You'll then hear of people deciding to raise funds or pay themselves to go abroad, and abroad meaning there's a couple of specialist centers in Europe. And the reason it confuses people here is they're saying, oh, why don't they just pay in Ireland? And the difficulty is that there's not much self-pay option in Ireland. And you also can't just quickly last minute pay for health insurance if you've never had it before, because they'll put waiting periods on you. So it's about kind of a confusing one in Ireland, and I'm far from an expert. I have private health insurance, and a lot of people in Ireland do. It is expensive, but it's just one of those things I was raised with. Even then, very few specialists in this country who use excision only, or who are very big, you know, they are big, you know, backers of excision. Very few who would use robotics, if you, again, not everyone, but, or if you wanted the really minimally invasive. So it's a hard country to be in. I mean, we've only got 5 and a bit million people in the country. So clearly you're just going to have a smaller choice. People do travel to the UK, and then you have the NHS and you have private healthcare too, but a bit different. But really long waiting lists in the NHS too. I mean, you're just talking about years. And again, similarly, the routes are up through a GP, hoping they will refer you to a gynecologist, waiting for that gynecologist to then hopefully do imaging. So it's a long journey. Some people end up going away, and they feel very hard done by that. They've had to leave, you know, a country that's got all the big tech giants and loads of wealthy people to kind of get things sorted. But I've been lucky. I've found a couple of specialists I've had kind of procedure with that are very on board for the multidisciplinary element of it. But the only thing is they're maybe not backed up by it. So what you won't get loads of here is that, you know, you'll automatically have a urology surgeon or a colorectal surgeon that all in together. Like when I had my bowel resection, I was kind of saying, and you know, asking those questions. And I think they're a bit like, why would you, you know, would you ask that? So yeah, Ireland is, I wouldn't say it's one of the worst places to be, but it's still quite difficult. And I think people look to you guys, especially with social media spread, and they see just so many specialists and so many hospitals and so many ways, and they're maybe not realizing how the out of network thing works. Yeah. And how much, because I looked at it at one point just out of interest, and how much it would cost. And they're also maybe not realizing that people are, you know, remortgaging houses and stuff to do it. So it's hard, because I think sometimes, and it isn't just Ireland and England, people from abroad just see people going and getting things sorted and amazing surgeries and thinking maybe it was kind of done on something like a public system. It's not. And you and I have spoken about it, right? It's a very complex,
very disheartening.
Yeah,
because I've said this before, it's like you have to be rich to be sick with this disease.
Yeah,
everything's out of network. So many things are out of pocket. Yeah. It's fighting with insurance. I know there's a fight with coding right now that they're taking to the hill. Yeah. In the United States, but it's just there's so many things that we're behind on, and then when you get into the extra pelvic coding, and well, why would you need a urologist for endo surgery? Yeah. And no, we're not going to cover that, and the battles, and like you said, people using their 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 wedding money that was put aside since they were little for their excision surgery, or like you said, remortgaging their house, or people just saying, I can't afford this, and not getting the necessary medical treatment they need. So to see like the comparison, but I am so thankful to have met you and to have you here today to talk so freely about your journey. And I know that you really haven't been public about it. So to come here and to trust us within the endo community means a lot.
It's been great. Thank you so much. Hopefully it helps one or two people. And if anyone ever has questions, by all means, get in touch with you. And I'm more than happy to talk to anybody anytime.